So with my talk this morning in diagnostics, I'm going to divide it up into two main categories. Diagnostics, which in my opinion is sick pig work. So people will call you when you have sick pigs or you're sending tissues away with sick pigs, as opposed to surveillance testing. So sick pigs, we're going to use tissues, and now we can use oral fluids and serum for that. Surveillance, primarily oral fluids now and serum. So no tissue on the surveillance testing. You don't get enough tissues sent in, enough cases for surveillance. So two big categories. I'm going to start with diagnostics. So, you have to look at the cost. What's a good number to spend on diagnostics? What's a good number to spend on sick pigs when you have, how do you figure that out? What are the benefits to sending something away to the diagnostic lab? Are you going to use that information? Some people get it back and then decide not to do anything with it. So I guess, some people, why do you even bother sending it in? So how much is the right, what I'm going to try to answer today is how much is the right amount to spend on diagnostics and or surveillance? And of course with many lectures, the answer to that is, it depends. Okay? Depends on how big the producers are, where you're at in the country, your geographic location, what you're trying to find, what you're looking for, and so on. So how much to spend is up in the air right now, but hopefully I can dial down and help you with that. So I'm going to start with small farms, backyard farms, and work up, okay? So small backyard farms, I still do some of this work, and particularly in the show pig world, those pigs are really important to those producers, and I'm going to call them producers, you may not, but they want to know why a pig died or why a pig got sick. And oftentimes with this group, with the real small guys, money is usually not an object. It usually is, find out why this pig died. I don't care what it costs, because I don't want it to influence the rest of my herd. And I always even get comments like this, test for everything, doc. So they've never looked at a submission form that has 150 different tests on it. So we usually have to pare down for that. This group does little or no surveillance. It's all sick pig work. And they're the group that often needs the most help because they're inexperienced. They're not familiar with the diseases, they're real naive, and they often make bad decisions as far as health. They're commingling pigs from different sources, they're not doing their homework, and we do more individual care with this group, more surgeries, and more individual, actually get back to our roots with individual animal care with this group. So getting a little bigger, a small independent producer, granted those are fewer and far between anymore in my practice compared to 20 or 25 years ago. But I find this is the toughest group because they really don't have a whole lot of money to spend on diagnostics, and they might have a pretty serious health concern, but they're trying to cut costs wherever they can. Some of these guys are trying to make a living at this, and I'm calling these 100 to 200, maybe 300 sows. They're really struggling. A lot of times they're older producers who are just kind of dragging things out, using their buildings up before they retire. And they rely on us veterinarians, I think, a lot more to just give them their opinion. Well, it looks like flu to me, so let's treat it like flu. Or it looks like this. So they're relying on our experience and our expertise to help them with the diagnosis as opposed to sending tissues in because they don't have very many animals to spend or to spread that cost over. So they may forego sending tissues to the lab. And treatment is more of a shotgun approach. Well, let's try this in the water, or let's try that in the water. And if that doesn't work, then we'll reevaluate. And again, surveillance is pretty unlikely in this group. Mostly it's sick pig diagnostics. So then we move to the larger independent producer, and this, in my definition, 1,000 sows and up. And you might get into several thousand sows. So larger producers, they definitely have a budget, or at least they know how much they want to spend on diagnostics. They have more pigs to spread those costs over, so it's not quite as tough a decision to send tissues away. This group often is starting to combine surveillance with their sick pig work because they want to know what's happening. They test their gilts before they come into the sow herd. They're more conscientious to what they have and what they can prevent from bringing in. And they need to know exactly what's at fault. They don't want the shotgun approach to treatment. They don't want to treat unless they know exactly what's going on and what they're treating. And also in this group, as you get to the larger independent producers, they're starting to have administrators, controllers, who they answer to about, why are you spending this money? Why are you spending this money? And they don't understand what the benefits might be. And then we get to the integrator or the managed herds. So these are the real big ones, several thousand or even 100,000 sows, like the Seaboards we heard about yesterday and Iowa Select today. They often have some sort of a budget, particularly for surveillance. Maybe not so much for diagnostics, but certainly for surveillance. They track and separate sick pig diagnostics versus surveillance. And that'll vary if it's a multiplier herd or a GDU compared to a commercial herd. So this is not my world. I'm a private practitioner and I deal with independent producers, not integrated or managed herds. So I didn't know much about this. So I had this little 6 or 8 question survey that I sent around to 10 or 12 of my colleagues, friends and colleagues who have integrated production. So and the conclusion with all that, when I asked them, how much do you spend on diagnostics? Do you have it budgeted? How do you decide? Is it per sow, per pig marketed, and so on? And the answers I got back were all totally different. So there was no consistency whatsoever. So I'm just going to show you some of the things that I got back. The first one, and this was a veterinarian who works mostly with large either integrated or even large independent herds, and they figure 35 to 40 cents per pig marketed. That's all commercial. There's no genetic multiplier in there. That's just commercial herds. So 35 to 40 cents. That's diagnostics and surveillance. Is that right or wrong? I don't know. That's what they see. Next one. The budget is determined kind of by the system for this particular individual. They look at a system, so that would include sow herd, nurseries, finishers, maybe a boar stud, maybe a GDU in there, and they have a number for that whole system, and then as needed they can push money around, maybe more to the sow herd this year depending on what's going on. Maybe something happened in the boar stud, so they'll push more to the boar stud and less to the sows. Maybe the nursery is not even on the radar for a year. And they use historical cost to come into play and try to, last year we spent this much, let's try to do it on 10% less this year kind of thing. So looking at a whole system. And keep in mind also, a comment here, they're not restricted on new disease breaks. So PED this year, I think it's probably an accurate statement that nobody had PED diagnostics in their budget at January 1 this year. But now we're spending a lot. So new diseases aren't necessarily included in these things. This is the most detail I got from one of my colleagues. $45.91 per sow per year. But that sounds like a lot, but in this case, it's diagnostics, surveillance, medicine, and vaccines all wrapped into one. So that's a big number. So $45.91 per sow per year. And I divided that out. If it's 28 pigs weaned per sow per year, that's $1.64 per pig. And then the other number he shared with me is $1.60 per pig marketed. So you add those two together, and they've got $3.24 per pig marketed, and that includes diagnostics, surveillance, vaccine, and medicine for the entire system. Okay? Again, I don't know if that number's right. That's the numbers they use. Okay? So the bottom line is really difficult to give you an exact number on how much is the right number to spend on diagnostics and surveillance. For us, 4-star, again, we're 7 veterinarians in 4 states, 6 clinics. So I talked to Roger Main, and he got this number back to me. This is just sick pig cases for a 12-month period, June 1 through May 31. And those are only the tissues that went to Iowa State. So us 7 veterinarians had 308 tissue cases we sent in. Those are sick pig cases. Total cost of $56,000, and that is $182 per tissue case. So if that's a number you want to take home with you, that's fine. That's the average number of average cost of a diagnostic tissue case going to ISU from our group. Obviously there's going to be some variation in there. You might only ask for 1 or 2 tests on a submission versus 10 or 20 tests, but that's an average. So if you think about the private practitioners, every time you go to post a pig, it's going to be a trip call, your time, plus $150 or $200 for lab fees. So you can see why a small producer isn't going to spend $400 to have you come out and post a pig. Okay, so we have to think of other ways, be creative to get our information on these sick pigs in the diagnostic cases. So some new options. Again, farms have become more sparse and more rural, whatever that word means. It's difficult for an individual pay for veterinarian to come out and post 1 or 2 pigs, especially if a veterinarian has to drive. So what many farms are doing, and I know this has been going on in large integrated herds for many years, they train people, lay people, it might be a manager, production manager, someone like that, to do the postmortems, send the tissues away, and maybe even classify some of what they find into broad categories to give the ownership some idea what might be going on. So it's becoming more and more common for veterinarians just to interpret lab results and not really be involved in the tissue collecting and looking at the actual sick pigs. Just as an aside, my previous slide there talked about rural areas and rural veterinarians. So the one reason we have trouble with this is the government has 15 different definitions of rural. And the USDA uses 11 of those. And they go all the way from a county of 50,000 people to some people that's rural, all the way down to 2,500. So that's just an interesting aside on what the definition of rural is. So we want to leverage our resources. If the veterinarian can't be there, there's a manager or perhaps an intern or a student in the summertime that can post those pigs, get the tissues submitted, and divide those causes or reasons, cause of death, into categories. And as they get better, you can start out as broad categories. It's respiratory, it's enteric, it's a meningitis, CNS pig. So you start with 3. As that person gets more expertise, then you can add categories and get a little more defined. So I stole this chart from John Waddell and Dr. Carricker back from Iowa Disease Conference. So if you can't see it, I'll go over it with you. So you have a death. Is it an acute death or a chronic death? So you can classify that an A, C, or if you get out there and euthanize one, that's an E. So that's there's a letter, 3 letters, A, C, and E. And then you ask this question, was a necropsy performed? Yes, then you go down the tree. If no, then it's unknown. So an A1 is an acute death. We didn't post it, so we don't know. Okay? So as you develop your database, you can look at those numbers. If it was posted, then you can go down the chain. Was it CNS or central nervous system? You can call it a brainer as a reason too. Were all the organs stuck together? Real simple question. Anybody can see if the organs were stuck together. If yes, polyserositis. Were there lung lesions? Okay, that's a respiratory problem. Was there blood in the stomach? It's an ulcer. That's a number 5. So we have if it's on the chart as an A5, that's an acute death. It was a gastric ulcer. And was there blood in the intestine? That was HBS. And you can add numbers again as your person doing that gets more expertise. And at the last here, it's important to realize if you posted it and you have a lay person or inexperienced person posting and they don't know what it was even after they posted, which is, hopefully you have some of those, then it's an other. So I wanted to point out other is different than unknown. Unknown is a pig that's not posted. Other is a pig that is posted, but the person doing it didn't really know. And that's an important differentiation. You can take that, again, that's from Iowa State Disease Conference. You can take that and modify it to your needs. So what I did with that chart in the summer of 2011, had a large client, 6,600 sows. It was 3,300 sow herds. The production from one of the herds went all the wean to market flow. The other went through a conventional nursery. Called me and said, well, my post-weaning death loss is too high. And he said, what can I do? And I said, well, why are they dying? Is anybody posting those pigs? No. Okay. So with the help of Novartis and Zoetis, we hired 2 veterinary students, and they worked for us for 10 weeks, and they posted every single pig that died post-weaning. Okay. So they were given a car, went around to the nurseries, went around to the finisher, and posted every pig, and put those pigs put those reasons into broad category. So this is half the flow, the wean to market flow. They posted a total of 215 pigs. In the top 6 reasons, you can see there, this herd, the big thing was the problem with bacterial pneumonia and A. suis. Unknown, and actually that should be other. because we did post pigs and the students just didn't know what to call it. So that's other. Polycerositis, of course, that's might be parasuis or Mycoplasma hyalinus, HBS or twisted gut, meningitis, and I have some reasons there that meningitis might be coming in. In Michigan, of course, is a horribly deficient vitamin E and selenium, so we still get Mulberry heart disease. So our top 6 reasons in that flow were 73%. And they charted that by age of the pig as well, so we found at 6 to 8 weeks, we had a peak in mortality, and then out in the finisher, this was the ASUS that was hitting us about 13 to 15 weeks. We were able to put some water medication prior to this peak to lower that peak, and some feed medication in before that break with ASUS. So we reduced that death loss by about half once we got that program into place. And it wasn't horrible, so we brought it from about 5.5 down to about 2 3/4. The nursery finisher flow, they posted 108 pigs with the top 7 reasons. Interesting that polycerositis jumped to the top of the list there, 30% of the pigs. And I know from my experience it's a horrible environment in that nursery. So it's humid when those pigs get started, so it's not really a surprise to me. That, again, is supposed to be other, bacterial pneumonia, vitamin E, selenium, meningitis, HBS. And interesting, we didn't have any rectal prolapses in the wean to market flow, but we have them in the nursery. And I can tell you the reason for that is this nursery was built in about 1990 when a 6-week turn brought us a 45-pound pig, and now we're getting a 65-pound pig out of there, and they're putting the same number in. So it's extremely crowded at the end of the phase. They get laying on top of each other. Maybe a little bit of cough, and you get a prolapse. So we had 3 peaks in there, early nursery, late nursery, and early finishing, and we adjusted our feed and our water medication to fight those. So that was an example on how students can help you out by doing a large postmortem or necropsy session through a summer. So that's the end of my diagnostics. I'm going to talk about surveillance a little bit. This slide reminds me to change gears here. This is the Fox Glacier in New Zealand. A lot of the, if you're a Lord of the Rings fan, a lot of the Lord of the Rings films were shot either in front of this glacier or behind the glacier. It was a great place to visit. Would highly recommend it. So surveillance. What are we doing with surveillance? We're monitoring the health of the herd. We might be making sure that an agent like PRRS is staying out. We might need to figure out if a stable herd is becoming unstable or an unstable herd becomes stable. And we might use it to monitor subclinical agents such as ileitis, PED, something like that might be there but not really causing a clinical issue. Much easier to budget because it's routine. You're doing those things on a regular basis, every month, every quarter, something like that. The important thing here is to have a plan if you don't like the results. For instance, if you're blood testing an isolation barn and all of a sudden it shows up positive to PRRS, what are you going to do with that? Are you going to dump those gilts, get a different group? Unfortunately, I have some producers who their production is so tight in their opinion that they need to put them in regardless of the findings. So then I say, well, if you're going to use them regardless of the findings, why do it? So Dr. Hansen said in one of his lectures, monitoring for the sake of doing something does not justify itself in all but the highest health systems. So maybe you can monitor for the sake of monitoring in a high health genetic multiplier, genetic pyramid or something like that, but certainly not for commercial purposes. So have a plan when you do your surveillance. A couple things to do, just suggestions on what to do if the results aren't favorable. You know, if it's a PRRS issue in a sow herd, you find out all of a sudden it's positive. You might load, close, and homogenize. You might vaccinate. You might shift the wean pig flow to a different nursery. Institute McRebel management than the farrowing. You might, if it's an isolation barn, you may dump that to a different flow or to slaughter. If it's a flu thing, you might wait until they're done shedding. But this last one is not a good thing to do, in my opinion. We really need the gilt, so we're just going to put them in anyway. I always cringe at that, and usually they end up paying. So early surveillance. How many in the group remember the old SPF slaughter checks? So we checked 10 pigs. We're looking for lesions of mycoplasma pneumoniae, and that was a pass or fail system. The problem with that system, it was 10 pigs a quarter. Not very significant or statistically significant. But the other problem was if you failed, you just went home and got 10 more pigs and tried the next group, I even had some people that would raise their pigs outside for the slaughter check. I would go for a herd visit and say, what are those pigs outside, in hog panels in the yard? Oh, those are our slaughter check pigs. So, okay. It's a real small sample, 10 pigs a quarter, but if you remember that most of these pigs were small, continuous flow farms, maybe 30, 40 sows, all the pigs sometimes under one roof, and certainly continuous flow. So really, if you think about it, your chances, if mycoplasma are in there, your chances of finding lesions on at least one of those lungs was probably pretty good. The statisticians probably wouldn't like it, but so that's the early surveillance. Fortunately, we've evolved into more precise, specific routine tests. And this next slide I'm going to show you is really busy, and it can be altered to meet your needs and your individual system. And I got this slide from BI. And let me step down here. So that if you can read the bottom, this program can be modified according to the goal of production, status of the herds, risk of infection, and the pig flow. So this whole top thing is an initial test. So we test 20 sows by ELISA, 60 due to be weaned pigs, combine those, pool them 5 to 1, so we have 12 samples. Nursery, 4 ropes for oral fluids. Finishers, 4 ropes. In a GDU, 8 ropes. And that's an initial testing just to find out where you're at. And this, you can use it for any disease, but it was developed specifically for PRRS. And again, depending on the agent, you can adjust your numbers up and down. Then after you have that initial detection level so you know where you're at, then the routine, they're not suggesting doing any sows anymore with the theory that if the sow status changed, you're probably going to know that. Still do some due to be weaned pigs on a monthly basis, and then on a quarterly basis, nursery, finishing, and GDU. And if you follow this program, that's about $5,420 a year. I'm not saying that's the right thing to do, but that's a good model to start with if you want to really monitor closely. For PRRS, and the big integrators, if you've got 37 sow units like Iowa Select does, obviously they're probably not going to do each and every one like this. But that's a baseline. You can adjust it up and down for your own needs. Another type of surveillance, we talked about in diagnostics, having lay people diagnose. What we've come up with, or what we have done in my area, and several other areas, is the PRRS area region control projects. So we're surveilling as a region instead of individual farms. We're doing a whole region. We can monitor the status of a single farm or site within the big group and find out what's going on. We can look at active infections versus stable and negative farms and put that all in a map so we can easily see what's what. And we can look for infection moving across the area, and I'll give you a specific example of that. So our Michigan PRRS Area Region Control was the second one that was funded by the PRRS CAP money. It's not a big area compared to other areas of the country, but we had 110 sites. And we thoroughly tested those herds 2009, 2011, and 2013. Now, that's not to say we didn't do diagnostics in between there, but we did those 3 major tests and tried to get every herd if we could. With the help of BI, we mapped that and made a dendrogram with our isolates. One interesting aside, in 2009 when we started, that was all serum. 2011, we part serum and started to use oral fluids, and by 2013, it was mostly all oral fluids. So we transitioned into the oral fluids quickly. The other thing we did with our regional control project is we had a plan of action, and we distributed a protocol and a rope kit to all producers in the area. So if they had sick pigs, they hung a rope and got it to the lab as soon as they could, and those results came back to me. And a couple different times we found that a break was starting on one end of the area. And so we were able to warn the people on the other end of the area, and they used some vaccine ahead of a break. One instance it was a flu break, the other was a PRRS break. So we were using this for other information besides PRRS as well. So this is our map, just to get you oriented. This is West Michigan. Lake Michigan is over here on this side, almost in the picture. Grand Rapids is, city of Grand Rapids is up here. Kalamazoo is kind of down here. And this is a two-county area, but most of the density is in this area that angles here. That's about 5 miles wide this way and about 10 miles long this way. And it runs southwest to northeast. So what I was alluding to earlier is in 2011 we had a PRRS break, which was a fairly mild break, start over here and kind of worked its way up. Just like magic. So these guys up here, we were able to get some vaccine to them, and we feel like that might have mitigated some of the clinical signs. So that's what we were doing with our maps. So the regional surveillance helped us that way. And then our dendrogram, that's going to be hard for you to read way back here, and I've got some notes on that. Interestingly, most all of our field viruses, this whole top half, and this is our isolates through 2009, 2011, and 2013. They're all in there. If you get up close, you could see that. But this whole top half, our main field virus was a 118.4 cut pattern. It was a fairly mild virus as far as clinical signs. There was one 128.4, a 126.4, a 113.4 in there, but by and large it was all 118.4. And that was the majority of our field virus. You can see it's all fairly close. This section here is all fairly close to the modified live vaccine, so we had some herds with the MLV vaccine in that section. This section is actually from the east side of the state that Barb Straw put on our dendrogram when she was still around. That really didn't have anything to do with our West Michigan project, but we just left it in there. That was a 124 strain, 120-4. And then we had 5 isolates here. Our four of those were 131, and this one out here was a 135-1. So that was a little cluster by itself. And then these 5 isolates were a 132, which is consistent with the Fostera PRRS vaccine. And here is the ATP down here, a 142. So you can see that was considerably different than anything else we had found in the area. So we had one big group and then 4 smaller groups to monitor. This one down here is an interesting story that came out. A good thing with our area regional control program. This was a nasty 144, one isolate there. You can see how much different that was from the rest of our isolates, and we think that's why we get along pretty well in Michigan, is we don't have any real aggressive, nasty 144s. What happened there was there's just a few slides on the diagnostic lab perspective. 10 years ago, even before PCR, you would send stuff to the lab and request an IFA, an SN, maybe a virus isolation, maybe histo. Now with immunohistochemistry and PCR and sequencing, these tests are really old time. I'm sure they hardly ever get requested. PCR, or molecular testing, is now the most requested test at the ISU Diagnostic Lab. It's very specific, it's very quick, very sensitive. And again, our thanks to Roger Main from ISU, shared this data with me. This is for the fiscal year 2013 at Iowa State. You can see pharmacology, tox, virology, and research and development account for only 5% of the testing. Most of the virology now is molecular, 42%, and most of them you can tell they're viruses because they still do a lot of bacteriology. So between bacteriology, molecular testing for viruses, that's the vast majority of the testing they're doing now. And 10 years ago, they probably were hardly doing any PCRs. So it can change. And this is their fiscal year 2013, almost 56,000 submission or cases, and 500,000 individual tests. And I took serology out of there. Serology was another big chunk, but for a diagnostics, I took that out. So these are, again, back to tissue and sick pig diagnostics. So in my opinion, one of my conclusions, oral fluids and PCR testing has revolutionized the world of diagnostic testing. The oral fluids is very easy. Not only, it's even easier for lay people to do than posting a pig. We can get a lot of information in a short period of time by hanging some ropes and getting oral fluids, and they can be used both for sick pig diagnostics as well as surveillance. Lay people can collect them, so we've kind of came full circle of how we're going to leverage our knowledge by letting lay people do more of our diagnostic work. And this, again, Roger Main from Iowa State, this is how their oral fluid numbers have increased over the last 3 or 4 years. 10,000 oral fluids in 2010, 30,000 in 2011, and 2012 and 13, about 50,000. So a lot of spit coming in. PCR tests for new agents can be developed very quickly, and we saw that with PED. So another advantage. And again, as of April 1st, I'm sure the diagnostic lab or any of them had not done any PED testing. 5 short months later, 6,000 tests for PED, all by PCR at $30 each, so $180,000 spent as an industry just at ISU, and that doesn't include South Dakota or Kansas or Minnesota. Just got the IHC test developed. That's going to be $13 a piece, so they haven't run so many of those, but I'm sure that will ramp up very rapidly. And what about new tests? They've developed it rapidly for porcine epidemic diarrhea, foreign animal diseases. We got to be ready for those if and when they hit the shores, and other viruses. I was reading our local paper, and they have every Sunday in our paper they have kind of a disaster corner, and they talk about all the floods, hurricanes, typhoons, earthquakes, nuclear reactor accidents, locusts, all the bad things that can happen. And a couple weeks ago, there was actually one that said, you won't be able to read this, sorry about that, but new life form. And what it says is French scientists say they have discovered 2 new viruses so different from anything ever before seen on Earth that they might as well have been from outer space. They call it new Pandora viruses, so named because opening them has spawned so many questions about nature of life. One was found in a freshwater pond in Melbourne, Australia, and the other off the coast of Chile. So brand new viruses, 90% different than any other virus they've ever found. So how fast are the diagnostic labs going to be able to respond to a new virus like that? After the PED issue, I'm pretty confident they could react pretty fast. So it's a new world. Tissue diagnostics, we have more lay people submitting to get good information. They don't have to call the veterinarian per se anymore. Use that flow chart to gather data, put that in your database, and maybe make some decisions about treatment and prevention. Oral fluids are very easy to collect, and our PCR tests are very sensitive and specific and can be developed very quickly. On surveillance, now we're using a combination of oral fluids and serum instead of just serum to precisely monitor individual herds as needed. Regional projects like the regional PRRS, we've learned a lot from that, and now that the PRRS cap money is complete, I'm hoping that those ARC projects will move on for PRRS and others, flu and PED. And the diagnostics lab did a great job improving their existing tests, giving us what we want, trying to keep it cheap. So kudos to the diagnostic labs as well.